Hi there. Are we live? All right. Thank you all so much for being here. That first session was incredibly inspiring. Thank you so much to Lee and to the Autoimmune Association for having us. So I think we'll just start by introducing ourselves. So my name is Cheryl Crow. I have had rheumatoid arthritis for 20 years. Oh, no, sorry, 21 years. I'm 42 years old. I was diagnosed when I was 21. And so I've lived with rheumatoid arthritis exactly half of my life. And I've also been an occupational therapist for 11 years. For those of you who don't know what that is, it's kind of, I like to say an occupational therapist is like if a physical therapist and a psychologist had a baby. So we are all about the mental health as well as the physical side of things and blending those so you can function better in your daily life. And I started my own patient education and support organization called Arthritis Life. And I'm just so happy to be here. And now I'm going to hand it over to Emily.
Hello, thank you again for having me. My name is Emily Taylor. I'm the Vice President of Advocacy and Engagement for Solve ME. I hope you've heard of our organization, but if you haven't, we are a national nonprofit dedicated to ME/CFS and other long-haul diseases, infection-associated chronic conditions, and we're here today to talk a little bit about managing fatigue and some of the collected knowledge from our patient community in ME/CFS. And if you're not familiar with the term ME/CFS, that stands for myalgic encephalomyelitis chronic fatigue syndrome, which is the umbrella term that is referred to an illness that has been previously called CFIDS or chronic fatiguing immunodeficiency syndrome. It has lots of names, but most recently, ME/CFS is the preferred term.
Thank you so much. That I was going to ask you that to define. And when I'm giving my presentation, I will probably be using the acronym RA, which stands for rheumatoid arthritis. I might also mention inflammatory arthritis or autoimmune arthritis. That's kind of an umbrella term for the kinds of arthritis that are caused by an ongoing inflammatory autoimmune process in the body, as opposed to a more mechanical form of arthritis like osteoarthritis that is not systemic. So we're going to first, now a half hour to cover pain and fatigue is not enough time, we will say officially, to teach you everything you need to know. But we're going to give you an overview of how some helpful ways to approach managing pain and fatigue with these kinds of conditions, chronic autoimmune conditions. So I will first share my slides, if you don't mind, Tony. Thank you so much. So the predominant theory of what affects pain in all chronic conditions, especially autoimmune and rheumatic, is that pain is a biopsychosocial phenomenon. And this is, I'm not taking credit for thinking of this concept. This is something I was taught, 10 years ago in occupational therapy school. But pain is not just a physical phenomenon, although there is a heavy physical element. We have sensory neurons all throughout our body that go up to our brain and communicate what we are feeling: hot, cold, pressure, pain, hunger, thirst, all sorts of things. But we also have psychological and social contributors to the experience of pain. This is a really simple example, but when you say social, first of all, I mean context that you find yourself in. So think of social really broadly, not just your friends and family, but what contextually is happening in your life when you're experiencing pain. So sorry if I'm talking too fast. A little example would be if you're just going about your life, maybe you're walking into your kitchen to get some coffee and you step on a thumbtack, your experience of that pain is going to differ from the same person who walks on that thumbtack who's actually in the process of running away from a lion. Let's say a lion is chasing you. When you're in a neutral psychological or emotional state, that pain is going to be probably experienced as more acute than if you find yourself in the process of being in a true fight or flight state. So when we say there's a psychological element to pain, I just want to be really clear to say that it does not mean it's all in your head, quote unquote. It simply means that pain is processed in the brain, and it's not just one tiny little area. It's not like there's the pain center. There are multiple regions that are all involved. And the good thing about this model is that if we can turn the volume or the dials up or down in some of the other areas outside of your body, like the psychological and social, you might be able to have a positive impact on your pain. The next slide, I'm just going to say, last thing, is that, often in inflammatory arthritis, it can be very, very frustrating to feel like, wait, my labs are normal. Why is my pain so bad? Right. And raise your hand, or, metaphorically raise your hand, or put yourself in the chat if you've ever heard that. Your labs are normal, or your x-rays are normal. So there's strong evidence, according to this article, non-pharmacological treatment of pain and rheumatic disease and musculoskeletal disorders. The extent of tissue damage does not explain the intensity of self-reported pain. That is why pain is conceptualized by the biopsychosocial framework. So just wanting to validate you if that's been your experience. So I can stop sharing, Tony, if you don't mind taking my slides away. The other thing I will say, we're going to be talking a little bit more about tools in your toolbox for fatigue than pain. But in the context of an ongoing inflammatory condition, it's, the first course of action is, can you get your disease under control, whether that's through medication, lifestyle, and then it's also separating what you can control from what you can't. Let's say you develop a pain toolbox over time that includes things like, I have my biofreeze right here, which I put on my neck and my hands sometimes, or hot or cold modalities. And then I also have my coping toolbox that says, okay, even if I use all of my favorite best pain tools to reduce the pain, there probably will still be some lingering pain, and how can I cope with that? And that can be super helpful. Okay, so I'm going to hand it over to Emily. Do you have anything you want to say about pain before we move to fatigue?
No, absolutely. I think one thing I'll just add about both pain and fatigue is that one of these things that make these particular symptoms so gnarly and so difficult to manage in a medical setting is that they're invisible, right? And they're subjective. How do you measure pain? Like, we don't have a blood test to tell you how much pain you're in, and so it can be really challenging. So part of the barriers of dealing with pain and fatigue is the communication around how you communicate that fatigue to your medical, or that pain to your medical provider, and then how they classify that. So one of the things I'd like to start with is talking about the types of fatigue, and then we'll look at some management techniques that we've learned. And before I get started, and before I share my screen, my slides, I just want to share that this particular set of information is the collective knowledge of the ME/CFS community that I have kind of collated from both my own experience as a caregiver with my mother, who's been sick with this illness since 2008. And also as a professional in this career, I've spoken to and worked with hundreds and thousands of patients across the spectrum, and kind of our organization has collated that knowledge into steps that we can help share with other patients. And as we call it, the newbies in the space, now that you're facing this journey, what can you learn from 30 years of collected knowledge from this really active and engaged community? So with that, I'll share my screen and talk a little bit about the types of fatigue. So I'm going to start on the right and then circle around to the top. So starting on the right, cognitive fatigue and brain fog. This is a type of fatigue that most people don't think about when you think of fatigue. You only think about the ones on the left side, pervasive fatigue. That's sort of the, oh my gosh, I feel like I just ran a marathon and I'm super tired. That's pervasive fatigue. But cognitive fatigue is its own form of fatigue that is commonly referred to as brain fog in our community, fibro fog for those who might in the fibro community. In the autoimmune community, I think brain fog is a commonly used term. But this is the feeling of cognitive slowness or mental fatigue that can happen with and in response to physical fatigue as well. And they often come together as a package. So when you're communicating about this type of fatigue, brain fog is actually a patient term that many folks use to support that. But the cognitive nature of this makes it hard to communicate when you're in the depths of that symptom. Secondly, there's musculoskeletal fatigue. This is the fatigue that's in your arms and legs and the rest of your body. This is the fatigue that we often talk about communicating to your doctor, that my arms and legs feel like they're made of lead today. That heaviness, that density, that feeling like you're weighted by the sun holding you down. That can be the musculoskeletal fatigue. And that's different than cognitive fatigue. And that's different than pervasive fatigue. So all of those are different types of fatigue that you would want to communicate to your medical professional, and helpful to communicate in your own medical journaling and your own understanding of your symptoms to help manage where you can focus your treatments, or your toolbox. I love that term, as you manage your fatigue. I also want to highlight cellular fatigue. Cellular fatigue is not one you commonly hear about, but it's one that we get all the time in the ME/CFS community. It comes with mitochondrial dysfunction. These are folks who literally at a cellular level, as in the microcell of your body, the brain cell, the stomach lining cell, the skin cell, is not creating energy at a cellular level. This is a dysfunction with your mitochondria, which are the powerhouse inside your cell. And this fatigue can be especially invasive and especially debilitating, because when it hits you, it's not like a particular area or a particular focused feeling. It is like, as my mom describes it, someone took a 2x4 to the back of your head and just wailed you down, and you just flopped, and it is, your whole body shuts down. So that's another area. So if you're experiencing that kind of pervasive body, like mind, all-encompassing fatigue, definitely talk to your doctor about mitochondrial dysfunction, because that's a specific type of fatigue that can be hard to parse out amongst the other experiences. We touched on pervasive fatigue, but I'm just going to come back to it. This is we often describe this as feeling like you've run a marathon even though you only just got out of bed. This can be linked with unrefreshing sleep. So that's another characteristic and symptom. So I wanted to kind of note those separately. But when you're speaking about your fatigue, I would recommend delineating or just differentiating the type of fatigue you're feeling, and describing pervasive fatigue versus the musculoskeletal fatigue or the brain fog. And the last type of fatigue, and I saved it for last because it's, again, a little complicated, is what we call post-exertional malaise, or PEM. It can also be referred to as PENE, post-exertional neurological exertion, or post-exertional neurological exacerbation. This particular symptom is unique and is the hallmark symptom to ME/CFS. So if you are experiencing the symptom as I describe it, and it is very common in other illnesses as well, you might want to get checked out for ME/CFS. The nature of this symptom is what we call the push-crash cycle. It's articulated or highlighted by experiencing the fatigue between 24 and 48 hours after an exertion or an event that would prompt this fatigue. So we call it triggering. So for example, if you're having a good day and you feel like, you know what, I'm going to go out to the park today, or I'm going to play with my kids, or I'm going to run my dog, or whatever that thing that you want to do is, and you do that thing because you're having a good day, and then the next day you are wiped, and you track that over time, that is post-exertional malaise. And it's characterized not only by that pervasive fatigue, the musculoskeletal fatigue, the cognitive fatigue, all the fatigue, but it also is an exacerbation of existing symptoms. So if you notice that your pain, for example, flares after an exertion, and you're in that push-crash cycle, it might be post-exertional malaise. And I highlight this symptom because it's unique, and we still don't fully understand what causes it, but we do have some interesting treatment mechanisms that are not what's typically recommended for fatigue. And that's why it's so important that you really highlight, if you're experiencing post-exertional malaise, and I cannot say this with enough emphasis, do not consider exercise as a treatment. If you're experiencing post-exertional malaise, it has been documented thoroughly that you will actually get worse the more you try to push through it and exercising and push yourself through it. So if you, again, just big red flag, if you are experiencing post-exertional malaise, pause, hold on, and double check with your doctor before trying exertion or exercise, because post-exertional malaise can make you over the long term worse if you try to work through it. And the last thing I'll just add is being aware of orthostatic intolerance. It's not technically a symptom of fatigue. It's a symptom that you might experience when you get dizzy, when you stand. It's characterized by a lack of control of your autonomic nervous system, meaning your heart rate and blood pressure. So if you experience dizzy spells after you stand, or after you've been sitting for a long time, you stand up and your heart rate palpitates and you get those tachycardia symptoms. Definitely that's something to be aware of. It comes with fatigue and orthostatic intolerance and pain. They tend to be all together in one friendly package, but it's important to kind of understand the differences there. And again, if you are experiencing orthostatic intolerance symptoms, check with your doctor about other opportunities, and that might be different from your treatment of your fatigue, because that symptom is unique in itself. And now we'll talk a little bit about some management strategies. So we'll go to the next slide about how you can cope with some of these overwhelming, fatiguing symptoms. Next slide, please. Oh, thank you.
I think.
Oh yeah, I got it. sorry about that. So the first and most helpful tool in your toolkit in managing fatigue is pacing. This is the key treatment for those with post-exertional malaise, or PEM. So again, PEM is the worsening of symptoms following even a minor exertion. It's that push crash cycle. It typically happens between 12 and 48 hours after the activity, and it can last for days or even weeks, these crash cycles. Sometimes crash cycles can last for years. So pacing is the critical way to avoid post-exertional malaise crashes. And at first, I know pacing can be incredibly frustrating. I've done it for years with my own mother, and it can be so hard to say no to the things that you know you want to do so badly in your life. But it's about managing your energy envelope so that you don't go too far and you don't prompt those crashes. So over time, if you pace correctly, you can start expanding the amount of things you do over time through pacing without prompting the crashes that can be so harmful to your overall well-being. So there's some links that I'm happy to share in the version of the slide you get to take home, that all these items are linked. There's a pacing and management guide, a crash survival kit, a 4-step toolkit to avoiding post-exertional malaise, and then a really great NIH paper all about post-exertional malaise. So those are some resources that I'm happy to share there. The second item I'd like to share about managing fatigue is sleep health. People with ME/CFS and other autoimmune conditions often have severe fatigue that relates to sleep problems. They have what we call unrefreshing sleep, or the sleep when you have it doesn't actually make you feel better. It makes you feel more tired. So there's actually some really great sleep health practices. And sometimes it's just you need an extra sleep. Sometimes it's that extra length of rest. So maybe a typical person only needs 7 to 8 hours of sleep a night. Maybe with your autoimmune condition or with your chronic health condition, you might need 10 to 12 or maybe more. So learning kind of the sleep health that works best for you is really critical. Again, these are links to some really cool resources, sleep practices for CFS, review of the NICE guidelines for ME/CFS, and some better sleep practices that you can borrow from the ME/CFS community that might help you with your fatigue. Medical journaling is such an amazing resource. This is the one that saved my family because we weren't even aware that my mother was experiencing post-exertional malaise until we started tracking her symptoms in writing. And then we saw, oh my goodness, she's crashing after she does certain things. And we became aware that she was experiencing post-exertional malaise. So medical journaling, for those of you in the chronic illness community, I know you've probably heard it before, but I cannot emphasize enough how helpful it is to just every day take a few moments and just write down how your health was. Went to a wedding, had a great day, had GI issues from the chicken and or whatever it is. And then you start using those journals to kind of unravel the onion of your symptoms. And they can be really helpful also in the medical environment. The medical journals were what enabled my mom to get her diagnosis of ME/CFS in 2012. It took 4 years to get a diagnosis, but that's, I'm sure, very familiar to those in the autoimmune community, that diagnosis delay that can be so frustrating. But medical journaling is a really great tool that can help expedite that diagnosis delay. And last, support. Realize that you are going through a very difficult illness. Your body is not reacting the way normal bodies do, and that's okay. But that means sometimes you need help, and it's okay to ask for help. And that's why, as a caregiver, it is my absolute privilege and joy to help my mother with her day-to-day tasks. And sometimes even I have to ask for help because I need the support as well. So I cannot emphasize that asking for support, asking for help, sometimes you don't have to do it all by yourself. And as you manage your spoons, as we affectionately call them in the ME community, I highly recommend looking into spoon theory. It's the idea that you have quantifiable little spoons of energy and you get to spend them, and then you manage your energy by spending your spoons. And you can ask for support, get people to help take some of the spoons off your plate. If you want someone to set the table, ask. If you need someone to do the dishes that day, ask. Try to really build that support network and recognize and explain to your loved ones that this is a reflection of your illness, not your heart or your passion. That you wish you were there, but your illness is preventing you, so you could use the help. So I know we only have 5 minutes or 10 minutes left.
10 minutes.
10 minutes. So I wanted to get to some of the amazing discussion that we have planned, but those are some really key tools. And I just wanted to really share some of this collected knowledge, and hopefully others in the autoimmune and chronic illness community can benefit from that collected knowledge and have better health journeys as a result.
Yeah. Yes. And I also have a slide on fatigue. So I just want to make sure to get to that too. We have 10 more minutes as far as I understand.
Yes.
So, yeah. So no, it's all good. Just, so I don't want to throw a bomb into I was watching the chat and everyone's resonating exactly with what Emily is saying. The only thing I'm going to say for people with a known rheumatic inflammatory condition, it's a great example of the tools that you use have to be customized to the underlying condition. So it's a beautiful example that for those like me who have rheumatoid arthritis who don't have post-exertional malaise, actually one of the most evidence-based interventions for fatigue and sleep quality is exercise. And so it's not just throwing that out there that if you have post-exertional malaise, it's like a decision-making chart. Choose your own adventure. Yeah, if you have ME, CFS, you want to follow those, the recommendations to not overexert yourself. However, with inflammatory arthritis, if in the absence of CFS, ME, CFS, then exercise is really smart thing to do. So, but what I'm going to say that's on the slide is, so we just in the same way that pain is not just physical, it's a multifactorial biopsychosocial. Fatigue, pain interact and intersect with these other variables here that are really nicely conceptualized in this space symptom model from the University of Michigan, Dr. Afton Hassett, who has this wonderful book, by the way, Chronic Pain Reset. I'm not getting paid to say that. It's just a great book, very evidence-based. She's a professor at University of Michigan, pain science. And also her colleagues, Dr. David Williams, also and Shrep helped her with this model. But the space symptoms are sleep, pain, affect, that's emotions, cognition, brain fog, concentration, and energy, fatigue. So when you can make a positive impact, the good news is improving your sleep quality, like Emily was saying, improving your emotional state, whether that's finding little micro moments of joy throughout the day, joining a support group, getting therapy, getting validation, or you have something that positive you can do in your pain toolbox, those can have a positive impact on all the other variables like fatigue. The bad news is that a degradation in one of those can likely spill over to a degradation in all the other ones. So the most important thing I wanted to say about this is simply that that you can indirectly influence. So if you wouldn't necessarily think I'm in pain, I'm going to go sleep. Like you wouldn't know unless you knew how these were all inextricably linked. You wouldn't be like, you would mostly think about like the pain tools that are like, it's a pain cream. I put it on my body and it helps my pain. You also want to think more holistically about the other variables. And the last thing is if you have an autoimmune form of arthritis like rheumatoid, it's really important and you're having really, really bad fatigue. I'm seeing some people in the chat talking about, their fatigue is really debilitating. You do want to rule out other potential contributing factors, like talk with your doctors, make sure you don't have iron deficiency anemia or sleep apnea. To a hammer, everything's a nail, right? So if you have an autoimmune illness, sometimes it's like, oh, that's your RA. But actually it could be sleep apnea, and people with rheumatoid arthritis are at much higher risk of sleep apnea in the absence of other risk factors. Even if you don't snore, even if you're not obese, you are much more likely to have obstructive sleep apnea just due to your rheumatoid arthritis. And then step 2 is, of course, getting your disease under control if you can through medications and lifestyle, most likely in the case of RA, and then address whatever fatigue lingers. And you're going to have a fatigue toolbox, it's helpful to develop a fatigue toolbox, just like a pain toolbox. For me, my fatigue toolbox is sleep maximization, the just right levels of exercise, including weight training, resistance training, in addition to cardiovascular exercise that's at a just right level. I do find if I push my heart rate over about 140, I will get fatigued. But if I keep it under 140, so that's like, you kind of need to end up looking at yourself like a detective over time, gathering your data. And it can be very stressful. So I want to validate that. It can feel like the target or your body's constantly changing. You're like, well, what worked yesterday didn't work today. That's where we have to do our stress reduction techniques, because it's a lot to handle these conditions. And then you might want to also you might discover your own unique additional fatigue triggers. For me, sunlight or excessive temperature changes, and they are huge. If I go out in the sun, I'm going to be fatigued. And then nutritional variables. I personally don't have any nutrition triggers, but they're really common. Some people, if I eat gluten, I'll be fatigued. I was really sad. I'm like the one person who went gluten-free, and I'm like, it made no difference. I'm so sad, but it's okay. That's part of it. It's a journey. So, okay, we can take away my slides now. Is there anything else you wanted to say in the last 4 minutes, Emily?
Oh my goodness. I love the space of all the different symptoms. I think it's important to realize and accept that unfortunately our medical system thinks about these things as like, this is your head, this is your heart, this is your stomach, and sort of piecemeals our bodies. But the reality is our bodies are all interconnected. They're all those things are in us working simultaneously. And so that's why, again, I love the medical journaling technique and so becoming your own detective, because it is unique to your body. And so what exercise might be okay for my personal health is not okay for someone else's. And so I know many ME/CFS patients that wear heart rate monitors or wearables that count their steps, and they know that, just as you described, if your heart rate goes too high, it's going to trigger post-exertional malaise. Or if I do too many steps today, if I do over, and sometimes that can be as small as like 300 steps, which is just walking around your house a little bit, is enough to trigger post-exertional malaise. So it's kind of starting to learn what is the right metrics for your body, and then working within those and then expanding them over time. I will say I like to share my mother's story as a little bit of a hopeful story, because when my mother was very first sick in 2008, she was entirely bedbound, couldn't eat solid food. I mean, truly was so entirely debilitated. You would have thought she was in a coma. She had to have her eyes covered because of the sunlight was too much. It was a truly zero quality of life way to live. And through, it took us many years, about 5 years of process and medical journaling and symptom and food and all of these different aspects. But with the right medical help, and again, medical partnership is key. Talking to your doctors as a partner in your journey, not as sort of the authoritarian that tells you what to do, and they need to listen to you, building that partnership and relationship with your doctor. And we are now in a place where she's not cured, but she is like 60% of her life back. She goes to her business twice a week. She comes back. She's out of bed at least 2 times or 3 times a day. And that's like 60% of my mom that I didn't have before. So with patience and with perseverance and with a good medical team, these conditions, you can get your quality of life back, even though you might still be sick and it might not be a cure, but you can experience all the things that you find joy in by those incremental changes towards progress. So that's why hopefully these tools will be helpful to you. And please feel free to reach out to me. Our email address for our organization is solve, like solve a puzzle, SOLVE, CFS at solvecfs.org. So just the same thing, solvecfs.org. Please feel free to email us out. We have resource links for all of these different areas. And if you think that post-exertional malaise and ME/CFS might be one of your syndrome soups in your diagnosis, we're happy to provide answers and hopefully help you on that journey. So that's my final thoughts, is that it's all part of your body. And the more you can be in tune and manage it and keep track of what triggers your body, the better your overall health will be.
100%. And you've done amazing work, Emily. So thank you for continuing to be such an amazing advocate. And yeah, I would just add the concept I use is like becoming the CEO of your care team. Like, with great power comes great responsibility. And when you're tired and in pain, it's annoying that you have to be the one. Okay, I'm going to validate that. But
Yes.
The fact is, there's no other person out there that's coordinating your care for you, usually, unless you have a wonderful person like Emily for her mom helping. But a lot of times, like I was just waiting. When I got diagnosed at 21, like, I'm waiting for some amorphous being to like coordinate all this. And then I finally realized it's me. Like, I guess I'm an adult now and I have to coordinate it all. So anyway, I know we have to speaking of pacing, we have to give you all a break. But if you do want to follow up with me, I have an exhibitor page here for Arthritis Life, and it has some links for a little discount to my Room to Thrive comprehensive self-management program, or you can just email me info at myarthritislife.net. And we are just so grateful for the chance to connect with you all. And thank you all for the wonderful comments in the chat. And then so you have a break until 12:50 Eastern time. All right. And 9:50 Pacific time. I'm here on the West Coast. That's why I still have my coffee. So cheers to you all. Take it one day at a time, and we'll see you later.